I'm David Ridley. Our guest today is Dr. Mandy Cohen. This event is sponsored by Kester Freeman in support of public health education. I think many of you know Dr. Cohen from television and the COVID epidemic, and because she's one of the leading authorities on public health in the United States. Dr. Cohen has degrees in public health and also medicine. She has served at the federal and state levels, and also more recently in business. So at the federal level, she was Chief Operating Officer and Chief of Staff at the Centers for Medicare and Medicaid Services. Then she came to us in North Carolina, served for 5 years as Secretary of Health and Human Services. And just in the last few days, really, she's joined Aledade. So Aledade helps physicians navigate the world of value-based care and accountable care organizations. So thrilled to have Dr. Cohen with us.
Thanks for having me. This is great. Hi, everyone.
So I want to start off by addressing what I consider the elephant in the room. So Dr. Cohen served for 5 years as a leader in North Carolina. And on Saturday, we have probably the biggest event ever in North Carolina. Fair? I mean, so the big question on all of our minds is,
who's going to win?
And more importantly, do you support good or evil?
Historic times. I love it. That I've been at. I was just sharing with David. This is my second talk this week on the Duke campus. Someone's going to have to get me in office. Indeed. However, I've been in politics long enough so that I will be keeping who I am rooting for to myself. I hope North Carolina wins.
The state of North Carolina.
The state of North Carolina.
Yeah, indeed.
The state.
Indeed.
So, it'll be a good game. I'm excited. Wow. I will say my former boss, the governor, is very clear on who he's rooting for, and so sorry guys, but I'll hold that to myself.
Well, I know you to be a good person, so I trust that you'll make the right choice.
Thank you.
Good. So you've been a leader in many settings, federal, state, and now business. Can you describe your leadership style?
My leadership style. So I'm a very values-driven leader, but I would also say that my leadership style changes depending on the circumstance. But at the core of it, I think values are really important to both articulate and then live every day. So my team, particularly at the state level, knows we had 6 values. I talked about them all the time. And in almost every all-staff communication in any meeting, I would bring those values into the work we're doing, being people-centered, proactive communication, transparency, stewardship, joy, and belonging. So those are the values that we as a team decided that were really important as stewards of really important work in health and human services. And we used that as our guidepost so that when there was tension and a hard decision, I'd bring that into the room and say, are we living up to our value of transparency here? How are we thinking about stewardship in its tension with being people-centered? As we make a hard decision to say, should we fund this or that? So values for sure, but I would also say leadership style has to change with certain circumstances. And I would say as I led through COVID, I was much more of a directive leader than I would have said my first 3 years at the state, where I would have said I was a much more collaborative consensus building leader. Not that I didn't listen to my team during COVID, but we were in such a crisis, we had to move so fast that there were certain times where I said, we need this by tomorrow, please go. We didn't have time for like the deep analysis, consensus building. So I do think certain different circumstances require different things from leaders, and adaptability is certainly high on the list.
Good. So, and adaptability is a hallmark of Coach K. I just wanted to put that in there.
Well, obviously.
Okay, good. What's an accomplishment at the federal level that you're proudest of?
Well, so I was very lucky to, sometimes it's better to be lucky than good. I just happened to be working at the federal level at a time that was one of the biggest changes in healthcare, the passage of the Affordable Care Act. Okay. And I was at the Centers for Medicare and Medicaid Services for the 7 years after its passage. It meant that I had a lot of jobs. First was launching the Innovation Center. I was employee number 6 or 7. So it was building we'll get to accountable care organizations later, but it was building a lot of the framework for launching new ways to think about paying for care. But a lot of my job turned into reacting to the crisis of healthcare.gov not launching in 2013. I don't know if you guys followed this. I'm like already dating myself, but I was working at CMS when healthcare.gov did not turn on. It was also the day the government was shut down, quite a banner day for everyone. And I was pulled into then the healthcare.gov turnaround. It's where I really, I think, learned a lot about crisis management and like leading in a crisis. And it was certainly the biggest opportunity for me career-wise, because in a crisis, when organizations are going through that, there are opportunities for younger leaders to step up and lead and help get the organization out of crisis. And I was lucky enough to lead a portion of that, and then with all of the turnover that happened, ultimately lead all of the exchanges work for the federal government before I took the chief operating officer role. So I'm really proud of the work we did to turn that around. It was, it was bad to start with, so the bar was low, so everything above, fixing it seemed better. But it was a great, not only learning opportunity for me, but thinking, how do you think through complex problems, lean on different teams for help, and navigate through some really, really challenging water. So proud that we were able to turn that ship around and now have millions and millions of folks who can get affordable health insurance across the country.
This is a great accomplishment. And it's an interesting point for young people early in their careers. If you go to a place that's in crisis, it's going to be stressful, but also an opportunity.
Yes. Tense, yes.
Yeah.
There's a lot of tension. But yes, huge amount of opportunity. And when you're thinking about the early parts of your career, I really would encourage you to put yourself in a place where you are building different skill sets, but also willing to say yes to things that might not fit into your plan, right? The things you thought you would be doing. For example, I'm obviously a physician by training, but to do the healthcare.gov turnaround, I was running call centers and in-person assistance, and I was writing. It was not in my wheelhouse, let's just say. But it was a crisis, and I said, put me in the game, coach, just to go with more basketball analogies today.
Thank you.
I would say I want to succeed at whatever job is given to me, so then I could take the next job. I wasn't going to run call centers for the rest of my life. I didn't think that was the last job I was going to have, but that was what was needed at the moment. That allowed me to build the skill, step to the next thing. So I'd say keep yourself open to that and look for an ability to work for leaders who will put their trust in you to lead big things. And I was very lucky early on to work for a number of leaders at the federal level who, somewhat out of necessity, had to put their trust in me, but they did, and it allowed me to leap forward in my career and my learning in a really exciting way.
Let's go from the federal to the state level. So the next stage in your career, what are you most proud of during your 5 years as Secretary of North Carolina Health and Human Services?
Yeah. So what a wonderful 5 years, and particularly 2 of them leading through COVID, which felt like 10 years. So, the thing I'm most proud of, and some would say, of course, it's got to be something COVID related. It actually isn't. It's one of the things of infrastructure, right? I'm a builder. I really want to make sure that there's infrastructure that is particularly left behind when I'm not there anymore, that's going to facilitate the goals and objectives that I was working on. And one of the things I'm excited that we built during my tenure was a statewide resource navigation platform called NC Care 360. It was something when I joined in North Carolina, I had a notion that we really had to think broadly about health. And as the Secretary of Health and Human Services, I know that health and human services speak different languages, even though we're trying to help those same families and communities to be healthier. And so NC Care 360 is the manifestation of wanting to bring health and human services and knit those together. It's a platform that allows for easy handoffs and closed-loop referrals between the healthcare sector and community organizations and human services. So if I'm sitting in my if I'm in my office, my primary care office, just as easy as I could refer to a cardiologist in North Carolina, you can now refer to a food bank and actually know, did the person get the resource they needed? If it was a housing resource, did they actually get it? And then you get sort of a closed loop to say, yep, we got you, Ms. Smith got to us, she got the resources they need, just like I'd want to know if they got to a cardiologist and what happened. So that's something that is statewide. We accelerated that work during COVID. I think it was a hugely important tool for us in our response effort. And so I'm really proud of it. Leave it behind and lives on beyond just my tenure there and beyond a crisis, right? It wasn't something we built for a crisis. It's something we build for the health of North Carolina going forward.
Some of our medical students are very interested in nutritious food for people and how that can, what they can do and how that can enhance health. And by the way, I have a few more questions for Dr. Cohen, but I'd be delighted to hear your questions in just a few minutes. I want to stick with the theme of health and human services. So you emphasize that you're Secretary of Health and Human Services. Can you give some more examples of how human services can feed into health?
Sure. I think they have to be linked. For those of you have heard me give a lot of talks, and actually I was just talking about a story I tell a lot as a physician where I did everything wrong in not remembering that there is a lot of health outside the walls of a doctor's office. I saw a patient when I was still training who had insurance. I could order any test I wanted for her, and I did. She came in because she was losing her hair, and I went down all of these different diagnoses of why she could be losing her hair: thyroid, anemia, Lyme disease, lupus, cancer, and I ordered a lot of tests, and I spent a lot of healthcare resources. And it's really easy to do. Click, click, click on your EHR to order tests and lab. It was very easy. All that came back normal. I spent about 8 weeks later, I see this woman again, and it wasn't until the nurse who checked that patient in came to me and said, I really think you need to ask your patient if she has enough to eat. And it turned out that she had left an abusive relationship, had so much shame around it, didn't want to call her parents because the parents really loved the boyfriend, didn't want to tell her friends because of that shame. So she was living out of her car. She was having that, cognitive dissonance of what was physically happening to her and what was happening in terms of her access to food, stable housing. That has forever changed how I think about that connection between health and human services. We have a lot of tools in the healthcare space. Like I said, labs and CAT scans are really important, but sometimes we often skip over the step of what really drives someone's health. And I'm working in my career, hopefully not just what I did at the state, but to think about how we really broaden the definition of health, but facilitate an infrastructure to make that possible, so that you have to ask in a routine way all the time about those sort of resource needs, and then you have to build infrastructure so that you can navigate folks to those resources. So that's what we're working towards.
Good. So we have a lot of efforts to improve health, and sometimes we think maybe those should be cost saving, but I'm not sure they should be. So is it realistic to think that these efforts to improve health will also lower costs, or should we just be comfortable with spending, say, 20% of income on health?
Yeah, I think we often have this incredibly high bar for certain things when there's more skepticism. Well, it has to have an ROI, but we spend plenty of money on things that don't have a return on investment. We just make that decision as a society. And so I think there are some times when return on investment is the right way to look at a problem. And there are certainly a lot of low-hanging fruit opportunities in healthcare where there are returns on investment, even in the human services space and linking that to health, that we haven't tackled. But at some point, we also that cannot be the bar that we're always asking, because it's not what we ask for, that standard is not what we use across the board. But there are places where I think in particular we need to do better, which is particularly around navigating to a resource. So for example, here in North Carolina, In the Medicaid program, which we know people are lower income if you're on Medicaid, we know it's similar income requirements to also be on the WIC program. A WIC program is getting food and diapers for young moms. For all of our moms that are eligible for WIC, and we know it because we have their income in Medicaid, only about 30% actually take advantage of it. 30%. That's really low. And that's an entitlement program. That's right there. That means we, North Carolina, are not taking advantage of a resource that's there. It's not new money that needs to be put into a program. We are just not accessing it. So when we talk about return on investment, I tend to think about how do we maximize the programs that already exist, make things, and what that tells me is we have not built a program around young moms that are resource constrained, right? And we haven't. You know why? Because you have to show up in person to get your WIC benefits every month. I will tell you, when I had a 4-week-old, like getting to some rando office was like not highest on my list. And so I just think we just have completely over-architected some of these programs in a way that it do not fit into people's lives. We also make it really hard to even have someone know they're eligible. They have to fill out another 15-page form when we have that information sitting in a different program and computer. So there's a lot of work to do that we are doing to streamline eligibility at the state level and things like that. But,
so I want to talk a little bit about your work in government and more recently your work with Aledade. So there's been a lot of interest recently, and actually going back to the 1990s, in providers bearing more risk through accountable care organizations or capitations or whatever the model. Is that model working? Mm-hmm. Is it providing savings? And how could it be better?
Sure. So should I define accountable care organization?
Yes, please. Yeah,
please.
Think
we're
no, you should. Please define.
So accountable care organizations are essentially a group of providers of care. They could be doctors, they could be hospital systems that have agreed to take on responsibility for an attributed population. So they say, like, okay, these 1,000 patients, or it's usually more, 10,000 patients are yours, and you are going to be paid differently to take care of these folks, and we're going to judge you based on both the total cost of care and your quality outcomes. Mm-hmm. And what I would say generally for accountable care organizations, they've done well on the quality side, which is great. You actually pay a little more attention to metrics, you tend to meet them. It's amazing. You measure what matters, and you can usually rise to those expectations. The issue is it saving money is the question. And what the literature and all the evidence has showed us is that the answer is sometimes. And the sometimes when it is working is when the accountable care organizations are physician-led, yes, not health system or hospital-led, which makes sense from where are the costs most. Most of the high costs are in the hospital setting, so it's really hard for the hospital as a lead to take costs out of its own work, because it's like taking one from one pocket and it's hard. I get it. And so generally hospital-led accountable care organizations have not shown the kinds of cost savings that physician-led organizations. And now it's not that surprising that I have now joined a company where their sole job is supporting primary care independent practices to lead accountable care organizations. It requires, though, a lot of infrastructure to do that, right? To coordinate small physician practices within one entity takes work, and to manage a population. And so that's what Aledade does, but it's been very successful.
Yes. I'm proud that some of that work that you referenced about physician-led ACOs being the ones to save money comes out of the Margolis Center. So my colleagues, Mark McClellan, Rob Saunders, and others did some of that work. And it makes sense if hospitals have beds to fill, operating rooms to fill, and physicians don't. But are there any independent physicians left? I guess you're working with the few that are left, but there are some left? Okay.
So Aledade in particular works with about 250 independent practices just here in North Carolina alone. And I'd say that if you look across the country, you add Alidade and all of these others together, we still have probably penetrated only about 10% of the market. Okay. So there's plenty out there. Actually, that's where the most of like real people get their care, not at Duke. They get it at independent primary care. And while independent hospitals are a thing of the past, I think, independent primary care is still there, but the world has changed. The kinds of infrastructure needed to be successful have changed, which is why I think you're seeing enablement companies like Alidade pop up to say you can stay independent. Alidade does not own physician practices. There are other kinds of competitors in the space that do decide to just own and buy practices, but that's not Alidade's model. It's said we want to partner. We want to keep physicians independent, but we still want to build these ways of bringing them together so that they can take care of populations.
Good. A couple more questions and then your questions. Should Medicare push harder for hospitals and physicians to bear risk?
Well, I think they've already stated that is their goal. So the team running CMS right now has been pretty clear that they want to see more patients in models where providers are taking on risk, because they see in the outcomes, as I mentioned, we see quality go up when patients are being seen in those models, and so that is a good thing for patients. So we want the quality to go up. I also think that in order for us to take costs out of the system, I think it makes sense for those who are closest to the care delivery to really decide how that should be done. And so I encourage providers to get into the value space and the risk-bearing space, because they need to be at the table to make decisions about, well, how should care get modified? So we don't get into a place where care is withheld or anything like that. Like, let's do it right. I think we all have a notion that there's waste, but waste isn't, has to really, you have to really know the clinical models to make sure that we take the right things out and leave the right things in. And so I think more and more providers should get into the risk base. CMS has stated it as a goal. I think you'll see more opportunities for that to happen. They just announced the new version of direct contracting models, or the REACH ACO model, just to show I think they are creating more opportunities for different kinds of entities to play in that space.
Good. Last question and about COVID. So you led the North Carolina response to COVID. Mm-hmm. How would you rate the CDC's performance on COVID?
Well, I will give us an A+. No,
okay. Sure?
No, look, it was a crisis. No one's perfect in a crisis, right? If you're getting an A in a crisis, then you're not grading yourself probably appropriately. And I think getting through a crisis is really all about both preparation and execution. I think on the CDC side, they were underprepared and their execution was lacking. I don't think anyone there would argue with that. And unfortunately, they had a few early missteps that really hurt their credibility long term. And it is why we at the state level spent so much energy and so much time and thought thinking about building trust from the beginning. And we knew if we had a data problem early on, erodes credibility. If we said we were going to deliver something and didn't, erodes credibility. And so we guarded that very tightly, and we also had a lot of humility in saying what we did and didn't know. And that is where I sometimes feel the CDC wasn't able to both articulate with certainty how to give advice, yet also articulate, we are learning, we are watching science happen in real time here, guys. Like, this is the best answer I have for you today, and here is with certainty what I think you should do today. But in 2 weeks, that may be different. And that was not easily communicated. I also think on the execution side, there are a lot of wonderful scientists and thinkers at CDC. They did not have the operational execution capability that was needed. And eventually we pulled in military resources and other parts of FEMA resources and others and put them together at the federal level, but it came way too late. And then you saw states fill that void. So North Carolina watched basically no help coming from the feds for 6-8 months. So we built our response. And by the time the feds did get all of those pieces together, we had kind of already built a lot of what we needed. I'm sure it was helpful for other states who weren't able to build as quickly as North Carolina, but I think there should have been much more federal coordination right from the jump, and more basketball references, and there wasn't.
Good. And we welcome any basketball questions. Yes, please.
So I hope you're cheering for Duke, and I know that given that you've been here twice in the past week, that's the case.
It's dangerous because right next to him is a Carolina fan. maybe even on both sides of him are Carolina.
Surrounded. So I wrote down my question. So like private nonprofit health systems are increasingly looking to take on more risk as validated health is sort of moving on. And I think downstream that's causing an increased focus on SDOH, which I think is a good thing, right? We should be doing more for food and housing for all these people. How do you think we as a society and the government writ large should view private organizations taking over some of I think what are historically more government jobs, like SNAP, for example? And do you think that there should be a limit on these private health systems doing that?
Yeah, it's a great question, and I actually think my answer has evolved on that question in our response to COVID. And here's why. Before we went into COVID, North Carolina had a first in the nation waiver to be able to pay for some of the social determinant kinds of things, pay for food delivery, pay for housing transition. And as we were building what would that look like, I felt very strongly that we not over-medicalize it, that we not have the traditional healthcare players now all of a sudden be experts in housing. I didn't see it. And in fact, I worried that, again, it would get over-medicalized, that we wouldn't build community capacity and resources. So we structured our whole effort in North Carolina, and we said literally in the RFP, you can't be a hospital system if you want to play in this space. I felt that strongly. Fast forward, we're in COVID. And we actually were able to run a version of that pilot using COVID dollars, not Medicaid dollars now, but we were essentially doing the same thing. We were using COVID dollars to pay for human services for selected patients. And some of it was if you tested positive for COVID and you were low income and you work a gig job, if you don't go to work, you don't get paid. So we created a program called the Social Support Program to basically do wage replacement, or we would do food delivery if someone needed to isolate at home, right? Those kinds of things. So it was the same kind of concept of a program. And now I'm building it in crisis, right? So I had to build it fast. The program we had been really spending thoughtful time in the Medicaid program hadn't even launched yet, but I had to launch something right away. And so I went out to partners to say, who's going to help me with this? And Duke was a partner in that program, and I will say was a fantastic partner in that program. Duke Health was. They were culturally sensitive. I think were very thoughtful about it. They also had they had capacity. They were able to scale and do those efforts faster than others. And so I started in one place where we never can have, and then I was like, wow, they did a really good job, and I want to acknowledge that in the COVID context. So I think the answer is somewhere in the middle. It has to be something with guardrails around it so we don't over-medicalize, but there are real resources and talent in health systems, and how do we take advantage of that from a scaling perspective? So I probably land somewhere in the middle now, where I was probably all the way to one side prior.
Aldo?
So kind of going on the theme of hospitals and providers taking on risk, what do you see as the role of the private sector, and particularly capital markets, and the government in helping fund that transition? Because it's not cheap to do, and it seems like only super large systems or Allied can pull that off. So people get caught in the middle. What do you think about that?
So, at CMS, we contemplated this. We didn't want it to be the haves that can transform and the have-nots can't. And so there was upfront resources for lower capitalized entities like FQHCs and smaller entities. And then I think the private market said, oh, there's an opportunity here. Let's see if we can make a business. Not every business succeeded, but ones like Alidate, I think, really have shown that there is a business model there. So I think that place of leveling the playing field really should come from the government, so it can be even. But I have less sympathy about infrastructure transformation for the big guys. Feels like they need to transform, but they don't. That capital, access to capital is not their issue. It's status quo bias, and it's hard to move big entities, and they're feeling quite fine where they are. So I think there are just different levers you pull to get folks to move into a transformation posture there. It's not necessarily upfront capital. They want more certainty. And so then I think there are levers that the government can pull around certainty as folks transition and figure it out. They don't need capital, but they do need, okay, if we mess this up, I still want to be whole, and I'm willing to try. But if you can keep me whole through my change management process, and I know by year 5 I'm going to promise you I'm going to be different, I'm willing to do that. Does that make sense? Right. So it's not like money on the table where I'm like, here's your upfront capital, figure it out, yay, go for you. But it is, I will help you manage through uncertainty until you can manage through that uncertainty on your own. And it has to be time limited. I think we tried to do that as we were thinking about our Medicaid transition work. There's a lot of changes in how everyone gets paid as we move to managed care in Medicaid. And we did think about those, how do we make folks whole while they figure out the transition? And I'm willing to do that from the government space. But I'm not going to give, no offense, I'm not going to give Duke a capital investment. You've got capital. You just have to decide to use it.
Agreed. Fair. Yes, please.
So sort of to that end, and first, Dr. Cohen, thanks for being here. A major critique of the ACO REACH model is that there are pretty aggressive risk caps set on providers that CMS would like to see go after maybe higher risk populations. So what is the appropriate amount of risk to ask ACOs to take on to make that transformation?
Yeah, I think we're all, it depends who you are and what hat you're wearing to answer that question. You need to have enough attribution and enough patience to spread your risk. I think you also have to have enough experience to be able to weather a bad year. I think you have to recognize that this is not a 1-year transformation nor a 2. Like, you have to be able to go through it. So it's more than just the risk cap. I'm answering more than just the risk cap question you asked. But I'll say so. The company Alidate that I joined did not participate in direct contracting in its first iteration because they did not feel like the terms were favorable. And I think you're seeing that play out in some of the publicly traded companies who are in the direct contracting space. They're not seeing the kinds of returns. Now, is it that that we just haven't cracked the code of it yet? Or is it that the parameters are not favorable? I think we're still figuring that out. I think with the REACH model, I will say my company looking at it says I think that is a place where we can be successful, particularly because of the emphasis put on underserved communities. I think that's a place where Alidate and independent primary care can excel in rural areas and underserved communities. So I think that's where the balance may way for us as we evaluate that opportunity.
My question was related to the REACH model as well. So saying in that thread, ACOs have done some things that are good, but the impact on equity has not been evaluated, hasn't been that promising where it has been evaluated. So with the REACH model and incorporating risk and risk adjustment models, the area deprivation index, other measures of social vulnerability, what's your perception of how successful that will be?
Well, it's good that it's, I want to applaud them for putting it as prominently in the model as it is. I think the data evaluation from an equity perspective on all these models has not been as good as it needs to be. I also think that there are some policy decisions that probably need to be changed in order to facilitate true equity going forward. You may have heard of things like the rural glitch, which I think is an equity problem. This is now we're in like the deep weeds of ACO policy here. Sorry, guys, but it's a lot of these models have to do with how you set a benchmark. And in rural areas, if you're the biggest player, right? There are issues with how those numbers get determined that I think disincentivize private companies from being in underserved communities. And so I think there are some rule changes that really need to be addressed from an equity perspective at CMS. I've shared some of that back with them. And there are other things like waiving of copays. As I build out parts of my company right now, I'd love to be able to waive copays for underserved, for folks who need additional services. That's illegal right now, right? That's an inducement. So now I'm a stark anti-kickback. Anyone want to start to go there? But at the same time, I want to deliver more care, and I'm not trying to induce them away from. They're already our patients. So right there are some frictions in the system around equity that I'd like to see the administration address. But I'm really happy to see their focus on equity in this new model and say we're going to measure it and we're going to hold people accountable to. I think it's great. I want to see that in more models.
Thanks, Krista. Travis?
Yeah, thank you so much for being here. So we know the payer market in North Carolina is, I guess, slightly unique with Blue Cross Blue Shield sort of dominating the entire, most of the market. How do you see it adapting over, and obviously Medicaid not have been expanded at the state level? How do you see sort of the changes in the payer environment? Do you see more insurance companies being able to come in the state to help drive down some costs with increased competition, or do you see sort of Blue Cross Blue Shield just continuing to sort of dominate this market?
Well, I think if they were here, they would say they're seeing a lot of new entrants in the market, probably driven by the Medicaid managed care transition, right? So you have United, Centene, big national players who are now have business here in the state, and it's a small piece of Medicaid business, but I think you'll see Centene, I'm sure, expand their exchange business in particular. So I do think that is bringing more payers into the space, and sometimes that's good, but sometimes that's complexity and administrative costs. So I think there's a tension here. One of the things that I appreciated about, particularly when Patrick Conway was CEO and he and I had worked together at the federal level, we had a lot of alignment on what we were trying to achieve. So he, as a payer, and myself bringing Medicaid to the table, if we could have alignment, that was a really powerful lever to get change in our provider community. When you fracture that alignment, then we don't get as much change in the provider community. And so I'm a little of two minds. I like the competition. I like competition for particularly lower costs for individuals on the exchange and for our employers. At the same time, we've lost a bit of alignment in that process as we've moved forward. So we'll just have to see how that plays through. And just having a dominant player does not always mean they're dominating in the right way. And so I don't want to seem like I'm advocating for that, but North Carolina was, I thought, particularly unique, and I do see more competition on the horizon for Blue Cross.
That's a really interesting point. So market power for the insurer might be bad for premiums for the patient, but good for leverage against Duke. So Patrick Conway can come to Duke and say, you better sign up for an ACO model.
Which ultimately will trickle down to benefits for the consumer. Now, it might not translate into that immediate in 1 year because, you got to get everyone on board and move but I think those are really important long-term plays for where we're going in healthcare. So you do have a trade-off there. New entrants to a market will try to undercut from a price perspective just to get into the market. And then do you really sustain those lower prices for fracturing that alignment from what you can get from your providers? So it's not a clear-cut, consolidation bad, more competition good. It's way more nuanced than that.
Yeah. You had a question earlier?
I did. Sorry. It was going back to the equity and reach model a little bit. So now that you've gone through both federal, state, and now private,
I'm 4 weeks into private. I don't know if that really counts, but
people are thinking about that as like Alliday considers the reach model.
yeah.
Clearly, some of the states have figured out how to address some inequities and come up with models for measuring it and creating plans, which is a key component of reach. Why hasn't like the federal government taken those learnings and applied it to the new model?
I don't know that they haven't, but you mean beyond the reach model? Yeah. Yeah. Why not? Because I've been there, change is slow. I mean, that's the short version of a longer answer, which I'll give, which is I think they're working on it. But, right, I spent a bunch of time right at the beginning of the Biden administration helping them understand what we were doing in North Carolina and saying, how do you expand what we've done and replicate in other states? And that was about a year ago. Had a couple more conversations, but I get it. I've been there. I've run it. There's a lot of initial work that goes into scoping that. The words you put on paper when you are at CMS are very powerful. Once it's out there, it has seismic waves across healthcare. So you got to get it right. So it does take time for them to figure out like what is right. How do we put that on a piece of paper that gets cleared by many lawyers as well as policy decision makers. So I think more is coming. So I know that they have been interested in the space. I hear them talking about concepts, but we'll see what's coming out down the pike. Mm-hmm.
Let's do two more. Let's hear from Audrey and then Jenny, and then we'll wrap, because at 3 o'clock there's virtual day at DUH, and Dr. Cohen has responsibility. So Audrey.
Sure. So Artie, Eli, and I are all in a high-value healthcare class, and we've been talking about ACO REACH a lot, which I think is spurring our questions.
And you know more than I do. Great.
One conversation we've been having is for like primary care physicians or physician-led groups. Like, is it worth it to enter into ACO REACH or just stick with Medicare Advantage? And some of the reasons are like there are some performance benchmarks that are really hard to meet if you enter into ACO REACH or some of these plans, or maybe even caps. What is your thought on that? Like, how do you weigh?
Yeah.
So, and maybe you can even have do certain things in health equity without being in the ACO REACH model and benefit in a different way. Do you have any thoughts on that?
So I think there are going to be different models that work for different size practices, right? Is it a multi-specialty group? Are you in? There's so many things that I'd want to know before helping someone evaluate what they should go into. I think either way, they're going to have to get good at certain core things. They're going to have to look at data in a new way for their whole practice. They're going to have to act on that data. They're going to have to manage transitions. They're going to have to look at annual wellness visits and really get, so right, there's like kind of a core set of functions that general primary care doesn't do on its own right now, and folks like Alliday come in and say, we can help you and coach you through that, and we can not only give you a data tool, we can give you a tool that lays over your EHR to help you manage this, and then we can help you get the best terms for a contract with your MA plan, right? So work with us and we'll get you, a good contract. So, and we can help you with MSSP, and we can help you can be in all of them. That's not exactly true, but you can particularly have some of your MA patients, and be part of that ACO at the same time that some of your patients may be in REACH or MSSP or something else. And so, but you still want to have a unified experience for your staff that is actually caring for patients. And so that, I think, is what Alliday can help provide, is that infrastructure to help be successful no matter the model. And I think that's why we're evaluating, should we help folks be successful in REACH? And that's just one of the many contracts we bring to a practice. We bring Medicaid contracts, we bring commercial contracts, hopefully we can get hopefully we're bringing contracts across their whole patient panel, because that way they're caring for folks in one way, not just, the MSSP get these folks, get this thing, the Medicaid folks get this thing. That's such a hard thing to track from a workflow perspective. So ideally, Alliday's working to get contracts across someone's whole patient panel.
Jenny?
Yeah, pressure's on. Last question of the day. I actually had a question more about crisis management. I was curious about your experience with like state-to-state relations and what that looked like during COVID, because as we saw, states had a variety of masking policies. Some states had shortages of PPE while others maybe didn't. So I was curious like what that looked like in terms of, was help along party lines? Were some states more insular than others? And your experience with sharing best practices across states?
So it's a great question. I think the CDC did facilitate some more formal across state line learning. I think that was, ongoing, that they had done pre-crisis and kind of carried into COVID. I'd say at the leadership level, right, my counterparts in other states, a lot of our sharing of knowledge really rested a lot on personal relationships. So I would probably the person I called most was the Secretary of Health and Human Services in Massachusetts. She worked for a Republican governor but when she was like, are you going to let them have professional football? And I was really like, nope. And she's like, okay, neither are we. It was like conversations like that. So, or I'd be like, so when are you going to think about lightening up a mess? They're like, next Monday. I'm like, okay, next Monday. Right. So it was also like a coordination of timing and those kinds of things. And I'd say I talked to my counterpart in Virginia, Indiana, again, but those were personal relationships, not a formal structure. And if anything, I think there needed to be a bit more of that. Atul Gawande, who is now at USAID, and I think from like writing fame, did pull a lot of state leaders together. I think the Rockefeller Foundation funded it, and that was really helpful. So like my deputy, actually Cody Kinsley, who's now the secretary, took over for me, really participated in that group, did a lot of lessons learned, but that took a while to get up and running. So the first few months, we were fighting each other, if anything. Like we were all fighting is not the word, competing with each other for the same resources. We were trying to get PPE, and we were trying to get the limited testing supplies, and we were trying to get ventilators, and we were all just like fighting with each other. Sorry, I keep using the word fighting. We weren't angry at each other, but we were competing, and we were driving the prices up. It was so bananas. It took us a number of months to get into sort of more of a cadence of how can we learn from each other, share with each other. We tried to do some group purchasing across states, and it really never worked, to be honest. I think some hard work went into aligning contract cycles, but procurement at the state level is super wonky, and every state has all of these other permutations, and we thought we would be getting somewhere, and we're like, okay, we're all gonna buy rapid tests together, let's do it. We're all gonna buy rapid tests. And then one state like undercut us on the price, and the whole thing fell apart, and we're like, no! So it never really panned out, so yeah. So then we bought our own rapid tests at our own higher price, and oh well.
Dr. Cohen, this was fabulous. Thanks so much for being with us.
Okay, thanks guys.